Wonderful. Thank you, Srinivas. And, I think without further ado, we'll go over to Dr. Grube and his team. Wonderful friend and colleague. And Dr. Grube doesn't need an introduction, but has really been one of the key pioneers in TAVR.
Yeah.
Oh, there. Wonderful. Okay, now we have your sound back.
Perfect. So Sheil, thank you very much for your very kind words. And I actually have two reasons to be very happy and very proud. As you can see, it's a little bit of a different environment. There's one person though behind me, Hendrik, who you know from Bonn. He changed now to Mainz, and this is, as you know, one of the most experienced centers in Germany with an incredible caseload. And next to me, or next to Hendrik, is Stefan von Badelim. He's already working, and Martin Geier, who is the operator, a very young, talented physician. And I have the privilege and honor to be here, moderate the case a little bit. I have to say though that there was initially a young, low-risk patient by Cospl. Unfortunately, this patient, before we could go live, the patient turned over to be a little bit unstable, and Hendrik had to operate on him. But we had a backup case, which we're showing now. Hopefully a very interesting case, because there are some important points to discuss. And maybe Stefan or Martin, he's working. So Stefan, first of all, thank you very much for having me. Hendrik, thank you much for having me. Maybe you can introduce the other members of the team.
Yes, thank you very much. Severe, actually, hypertrophy of the left ventricle. You see his 6-minute walk test is severely reduced, and the BNP levels elevated. His EAR score 2, even though being 93, is in the intermediate risk score level. So next slide, please. Kannst du bitte was sagen, Frau Brömer? Geht's nicht. So you see here the echocardiography. You can appreciate that we have a 2-centimeter thick septal wall. The LV ejection fraction is normal. We face a severe aortic stenosis, but the gradients are lower. You see the Pmax, Pmean values from echocardiography, but the index-less velocity ratio is significant with 0.25 according to the guidelines. Even in this old gentleman, the SPAP was only mildly elevated with 35 millimeters mercury. Next slide. So what we faced when we did the coronary angio in this old gentleman, you see we have a very nice right coronary artery, but we had and faced a left main stenosis at the distal portion. And this has been treated before. So next slide. So the discussion in the heart team was in favor of a PCI of the left main plus a staged TAVR because of the highly elevated age. The left main was treated, as you can see here, with 2 everolimus stents. Next slide. So now we come into the discussion, Eberhard, and we've seen these images before, Hendrik. So we have a tricuspid valve with a parameter of approximately 17.9 and an area of around 490 millimeters square. So the average actually diameter is around 25 millimeters. The coronary access is very favorable also for a supraannular self-expanding valve. So we have a left and the right main with 16 millimeters across the annular level. Next slide. The sinus is big enough. And the sinus is also, as Martin put it, big enough. We see we had a favorable, for this old patient, a favorable femoral access situation that we used. The marker catheter is coming from the right radial artery. So we have only one puncture from the right groin, and we have a pacemaker possibility from above. You can nicely see the heavily calcified situation in the left main and also in the circumflex. And you can see here the annular level that is calcified. The access side is very favorable. So we're far across 5 millimeters and even over 6 millimeters. So next slide. We will discuss together with Eberhard and Henrik, of course, what kind of new implantation techniques we can use. And to enable this, it is important not only to use the traditional three-cusp technique, which is shown on the left-hand side, which is an LAO 17 with a caudal 17, which may go further to the LAO when the wire is in. We have no horizontal anatomy, which is very, very favorable, actually, for the self-expanding valve. And on the right-hand side, Eberhard, we see the new Cospl Overlap technique that has been nicely described also from New York and with Gilbert Tang. And we see that we typically go slightly into an REO position, and this is like a textbook candidate, actually, because he's really on a caudal only with a slight REO projection. And it's very important to take these additional views. Next slide. So for the risk analysis, we also look, of course, for the movement we're able to do with the calcified valve leaflets. We're safe for the coronaries, and we have a very favorable QRS width of only 96 milliseconds in a very old patient. So I think this looks very nice. We see a membranous septum that is approximately 3.3 millimeters. Next slide. So the therapy was initiated to use the very new and 2021 generation of the Medtronic Evolut platform, and the iteration of the Evolut Pro switched to the Evolut Pro Plus, which will take over actually the sealed proportion to all valve sizes. So what we see here is that we have a high variability of sizes available to treat. So we can treat an annulus from 18 to 30 millimeters. And you can see that with this new platform, we also have a seal capability in the largest 34 millimeter device. Henrik, what do you think of these developments? I think it's very favorable to treat a lot of patients, especially also the North European patient type, which rather goes into the 29-34 range.
Yeah, that's a major advantage. And together with the advantages now, the introducer sheaths come back to smaller sizes, so we can treat vessels 5 millimeter in width. That's quite a step forward, I would say. Eberhard, what do you think?
Yeah, I think that's an important development, covering an annulus size from 18 to 30 millimeters. And excluding the 34 millimeter, you have a 14 equivalent sheath size. So it basically continues a favorable access, even though this patient had a good access, as you mentioned, Stefan. It's still good to reduce the vascular complications. I think what will be discussed while we do the case is the new technique. And now I know that you're there, Sushil, and I think I heard Vinny also. So we have a great group of people from our Indian friends that we have a lot of discuss here, because it's a low flow, low gradient patient. And obviously, if we look at the size, I think the team decided to use a 29 millimeter valve, which is very appropriate here for a 78 perimeter, if I'm not mistaken.
79, yeah.
Yeah, 79, and the calcium load is moderate to severe. As you can see, the take of the coronaries is favorable. So we concentrate basically on the technique of implant, which is new to many. We have to get used to it. The teams actually that are working every day, they're quite familiar with this, but I think we can discuss this, and maybe right now,
Can I ask a couple quick questions?
Exactly. Yeah, go ahead.
So I have Saurabh on the line, and Srinivas, and Sanjay, and I think a couple others. So this is a great case. I know it's sort of patients on the older end, but the low flow, low gradient, and the guidelines have updated, and I think that's an important consideration. These are patients that are often under-recognized as severe AS, and there are probably other concomitant pathologies like amyloid. So how do you convince yourself that it's severe AS? How does Stefan or Hendrik or Eberhard or others, what would work up, to make that distinction?
I think the indexless velocity range is a very good start to differentiate the need versus the non-need. But we also know, and we'll see more trials on this, that also the low flow gradients, especially in very stiff ventricles and also in moderately to reduced ejection fraction, have a mortality benefit if you really reduce the afterload by taking off even a 3 meters per second or more actually resistance to the outflow of the ventricle. Yeah. So these patients do better. And we have meta-analysis just recently with 6,500 patients. We have the circulation papers by the centers in the Netherlands that covered more than 300 patients. I think there is ongoing evidence, and we will see also trials in the future going for the low flow patients, especially in reduced ejection fraction, that they may have a mortality and hospitalization benefit. But this is to be shown in randomized trials, which will be ongoing next year.
But I think the point that Sushil is raising, with a low gradient, this, by the way, this patient is elderly, as you know, 90. But he's still very active, and so you can, we assume that once he's practicing his activities, daily activities, that the gradient situation is relevant, and I think you can do it in many ways to test and to define low flow, low gradient. It is an ongoing discussion, as you very well know, Sushil. Would you actually, at this age, Hendrik, I think this is a good TAVR case, but we still have to discuss whether there is a surgical option here also. Just a word on this?
No, in this case, no, actually. So that's a clear answer.
No word.
No. No.
But whenever you're in doubt about the low flow, low gradient, I mean, the degree of calcification in this case really gives the last hint you need, maybe. So if you see calcified valve like this, then the decision point is much easier to take, I think.
Yeah.
Hendrik, in the last session, something came up. Let's say this patient was 63, right? Sarah presented a similar patient. In the lifetime management, have you, what do you think about the strategy of, even in a 55-year-old or someone, doing TAVR first with the idea that you're going to go back and take this valve out later? On the surgical side, how do you feel about that strategy of saying, okay, in terms of sequencing, do TAVR, then surgery, then TAVR again?
Can I just, before Hendrik answers with more competence than me, I just thought I heard a word that it is easy to take an ingrown valve out. I have seen cases that is the opposite. And particularly the core valve, if you implant a core valve in a 65, which by the way is not covered by any guidelines and any reasonable data, but suppose you do, and and you want to explant it, this is not such an easy case, and Hendrik of course can talk more about that, but it's an ingrown of a tube, and you might actually end up with a root replacement. Hendrik, would you comment on that, please?
Yeah. Well, TAVR first, it's been discussed many times. I think we have to look at the anatomy first. It must be a very good TAVR candidate. And there are some scenarios where I could imagine that this is the way to go. If you have a very small annulus, by the way, where you know that implanting a surgical valve in a center that's not capable of doing root enlargement ends up with patient prosthesis mismatch. And in this such a case, I would definitely opt for TAVR first, because then you have the lowest gradient possible, maybe even the best durability of the valve. So it's not only looking at patient age and risk, it's more looking on anatomy, I would think, and then pick the perfect valve for that particular patient. So there are many questions, but rather to draw a line beneath it, I think surgery first in the younger ones is still a valid concept, but as surgeons we have to keep up and implant the correct valves, so the ones that are good candidates for a later valve-in-valve procedure. And we have to implant large valves and do root enlargements. If that's possible, then I would opt for surgery first.
Yeah, I think, Sushil, and we've discussed this, if I was 65 or 60, I would not start with TAVR unless there's a reason not to do surgery. I would start with surgery and a root enlargement, not implant a small valve, which we know will be a problem later. But I would go, if at young age, and that's actually recommended also, I would start with surgery and encourage the surgeon to do a root enlargement. There has been a discussion about root enlargements quite a bit at TVT. I understand this is more technique, it's more time, it's more risk, needs more experience, all of that. But if you look at lifetime management of these patients, I think we should strive to do the root enlargement if there is a small valve. But at that age, I would definitely go for surgery.
00, Felix.
So the other question in this case is great, highlights a lot of the issues. So the coronary disease. If this was a sapien, is part of the decision about fixing the coronaries that the access may be more difficult with the core valve, or if this was a sapien, you would have still fixed the coronaries first, or is there a scenario where you do the valve first?
Stefan, you made a point that was staged.
We definitely do in the majority of cases a staged procedure. This is because both the contrast dye exposure and the result is known. We would always try to revascularize the patient first and then go into a separate procedure and keep both procedures short and keep both procedures also conscious. This would be my preferred approach, to be honest.
There are certain patients where we've deferred coronary vascularization. In some selected population, our heart team has felt that actually TAVR is the lower risk of the two options, and let's just TAVR them first.
That is true. It's also dependent, certainly, if you have risks for ischemia, if you have the need for rapid pacing or just for fast pacing, etc. So there are many variables that also go into the equation. So it's not it's just a general tendency, but it's never 100%, of course.
Yeah, but I think what you said, Stefan, it is basically a risk evaluation. You don't want to add another risk if you can be reasonably sure that fixing the coronaries is doable with low complication rates. Then I probably think there's a good reason to do it. If there's any risk involved that might prohibit you from moving forward in a given coronary case with TAVR, then I think a staged procedure is also an option. I think we're ready to go. Is this correct?
Yeah,
Martin?
We just test the valve. So what we did before is the first thing is doing the access. That's the safety access with visualization and X-ray for doing the primary access with a distal safety sheath, and we did the we crossed the valve with a straight Terumo wire and switched over a long Terumo, and then we did already the marker pigtail via the radial side. So now we're checking the valve for correct loading.
And Sushil, maybe you can, you or whoever is there can comment on the overlay technique, or overlap technique, which is quite different. If I may just say the 2 or 3 key points. I'm sorry. The 2 key points are that moving away from the traditional coplanar view, you try to overlap the right and the left and separate the non in order to clearly define the membrane the septum, which we know is the target for conduction disturbances. That's number 1. Number 2 is the deployment technique. We try not to go into the ventricle, classic way, pull back, because we try to stay away from it. So we start high, hopefully. We start high and let the valve move down in order to not to get in contact with the membranous septum. And number 3, we try to get the head marker over into the outer curve. But most importantly, we want to make sure that this patient doesn't have any conduction disturbance. The other thing that I would like to mention here, because commissural alignment in this particular age group is probably not a major thing, but we are aware of it now in younger patients, not only looking at Cospl Overlay to reduce conduction disturbances and a foreseeable a discharge in one day, but also have commercial alignment, which is to say you align the prosthesis with the native valve in order to guarantee coronary access. So now,
Can
go
I
ahead,
ask a
Sushil.
quick question? So it looks like you're using a safari wire or confident, I'm not sure which.
Yes,
Yeah.
So there's just two camps about the pre-shape versus a Lunderquist. Some people are very adamant. I use the safari, but I know there's camps that are very adamant about Lunderquist. Do you want to comment on that? Or?
yeah. So we've discussed this obviously because that's a very good point. I think I shouldn't say Medtronic recommends, but they actually do try to recommend the Lunderquist because the curved Lunderquist, because it's supposed to give good and better support. It is what you're used to. I personally use the Lunderquist, the curved Lunderquist, because it gives me great support and kind of controls the valve movement a little better than the Safari. But let's see how we do. The other question here is pre-dilatation or not, given the calcification. I think the team decided not to pre-dilate. Is that correct?
That is correct. So we'll try
they're
to
implanting the valve already.
do that directly.
I just wanted to mention it.
So Stefan, what scenario would you pre-dilate? Is it bicuspids only or?
Yes. So we just want to show you here the introduction technique that you see for the curvature and for the new implantation technique, where the flush port here is at 3 o'clock.
For alignment.
For commissural alignment, yes.
It's good. And
Yeah.
the head markers on the outer curvature.
You see the head markers there? For now, you see it's a steep angle, but we're getting across nicely.
Slightly LAO.
Yes. And you see we're now diving into the valve.
Try not to go in too
No,
deeply.
No.
So
as
basically
mentioned.
the marker band should be at the level of the pigtail.
So do you do what, so some people have advocated putting the marker band at the middle of the pigtail and letting the valve come down. Is that? your
Exactly.
approach as
That's
well?
correct. That's
Exactly.
that's the approach.
And hopefully we can prove our point by looking at the EKG afterwards, right?
So we have two settings here. One is slightly REO. He is now going into this overlay technique, which is approximately 4 to 6 degrees REO, and which is then caudal, as you can see. And this gives us, as you see nicely, the non-coronary cusp on the left-hand side of the image, and we have an overlay of both the right coronary and left coronary on the right-hand side.
Yeah.
Okay.
And importantly, I mean, the deployment should be fairly slow. So we see how things are going, but that's an important step, that you don't dive into the ventricle and let the valve go down.
Okay, so we can do an angiography.
Do root shot,
Is it connected?
which right now
No, it's
doesn't
open.
show.
Oh, okay,
Do it again.
typical pitfall. Very good.
Okay, that's excellent. See this, Sushil?
Yes, that's great. So you have the marker band sort of in the middle of the pigtail. The
Correct.
pigtail
Yes.
As close to the base as possible in the non,
Correct.
and the right and left are overlapped here.
Yes.
All right.
Okay.
Absolutely.
The wire is, I think, in good position.
So yeah,
Okay.
we do similar. We use the Lunderquist in sort of a horizontal aorta or something sometimes
Yes,
to help us. but-
definitely.
But as I said, this is no horizontal aorta, of course, in this case. You can nicely appreciate that with a very nice position of the system.
Okay, so we would take a pacing of, Frau Professor Brimmerich, wenn wir 100 Pacing nehmen, 100 BPM.
Controlled pacing now.
What rate are you doing for that?
100.
We're doing 100,
Okay.
just to make sure we have no extra beats.
And
Okay.
Sushil,
So we
while
can-
they're deploying
Yeah.
protection, the
Henrik,
question
that's
didn't come up. As you know, here it's an issue. I don't think he's at high risk for using protection. Yeah.
Yeah.
But I would definitely do it in bicuspids, obviously in a heavy calcium load.
Bisschen time.
hopefully we will. Go ahead.
In India, unfortunately, serial protection is not available, so it's not used. But it's an important point. I mean, we do it routinely, but reimbursement's not as much of an issue here as it is in other regions. So I think that's the challenge. But you see how slow you guys are opening.
Yes.
I think that's a great demonstration.
I like that very much.
Yeah.
Very difficult for Stefan. He has a lot of temperament, as you know.
Yeah, but I'm also coming from AV valves, so they were always very slow, but one bite only, you know.
Super.
Sushil, you're the same, I hope.
Yes, absolutely.
So see, the valve does not. It's very nice.
Yeah.
It's very nice. It stays
And
there.
Martin does a great job in keeping the height. It's always a little pushing and a different power for that.
Okay.
Now it's slightly flaring. We try to connect it to the cusp.
Okay. Perfect.
Okay. See how it's coming to the coronary cusps.
Yeah.
Off.
So, no.
Yeah, but
That
that's just something that is not a problem here in this case, because we really want to go high. So maybe he starts a little bit slow, a little bit lower.
Perhaps we increase the frequency. The blood pressure was quite high in this patient,
Yes,
to be honest,
I
in
would
the
probably go
beginning.
to
So
180 when you.
yeah, we have to go higher also with the
was
the pacing.
Yeah, we're still bouncing a little bit.
Ja.
Yeah.
Gleich, wenn wir drin sind. Ich sage es an nochmal. Ja.
Once you get in contact
Also
with
Druck
the
darf
valve,
ruhig 100 sein. Also wenn wir da ein bisschen.
then it start bouncing, and the bouncing is really something that kind of pushes the valve up a little bit.
I think that's important, especially for the 23s. I've taken to, when it starts engaging at the just below the valve,
Right.
increase the pacing to 140,
Correct.
160
Yes.
briefly, just to
Right.
hold position.
Yeah.
As he is 93, we're a little bit reluctant, but I think you're totally right. And this is also the measurement we take now. Okay, ich mache ganz langsam. Komm, Druck ist super, Frau Bremerich. A very nice pressure.
Pressure is good.
And you pace, please, start pacing with 120. We can go up in the second half of the implant with 120 und dann sagen wir Ihnen Bescheid nochmal für Erhöhung auf 140 oder so. Aber so ist gut, so ist gut. We have 80.
So that's 120 now, a little higher than before. But when again, this is a good movement. When it starts bouncing, then I think it's good.
Ja.
Pressure is very good. 120
Very slow.
is going slow, as you see.
Ein bisschen höher.
Ja, genau.
And your goal is about 2 to 3 below, is that correct?
Yes,
Or-
that's correct. That's correct.
Yeah.
It is not heavily calcified, so you see it was good not to predilate in this case. Actually, this also gives us the same impression. Bisschen Druck, Gegendruck noch runter. Wir müssen ein bisschen mehr geringen. Ja, so ist gut. Jetzt ein bisschen höher. Der Druck ist 100, genau, ein bisschen höher. Pace noch 20, 140, danke. So we go to 140 beats per minute. Die Bewegung ist jetzt schlecht. Bisschen sedieren. Ganz ruhig liegen bleiben. Okay, mach weiter. Halt gegen. Ich mache auf, ja? Jetzt schneller. Ja, alles gut. Gegenhalten.
The patient wants to go.
Patient wants to be already discharged. I go.
Ist aus? Auge?
Ist er aus?
Einhand. That might be good.
Ja. Okay.
Und Aufnahme.
So we switch
Aufnahme.
now to
Aufnahme to LAO.
LAO.
Looks perfect. Very good. We switch over to 15 or 20, something like this.
See that, Sushil? This is now important
Okay.
that you know where the projection, the image intensifier goes to.
And
The valve looks good.
Very good.
perfect. You see, and we got a much higher situation also on the left coronary. Looks perfect for a conscious patient that was even moving. So we have a very nice situation. Ja, he wants to go home already tomorrow. So
Yeah,
he's talking with us on his discharge date.
And I think one thing I would emphasize, as you did here, again, patients
Okay, ist jetzt frei.
93,
Ja? Ist jetzt frei?
there's this goal that people have about being, the cusp overlap technique doesn't mean going to zero, right?
Yes.
No.
And I think that's an important consideration because that gets out there and everyone's like, it has to be a zero implant. It doesn't need to be zero. It's in the,
No, 2-3.
Yeah, 2-3
But
is,
you see,
is the goal.
Yeah, exactly. But the 2-3 in cusp overlay is not the 2-3 in the coplanar view. That's
Correct.
the most important point,
Yeah.
It's so here you can see, I mean, the beauty here is when you try to do this and it bounces, you can, close the valve again and reposition it.
And it looks like the valve expanded nicely as well.
Yes.
So.
Yeah.
No, we're very happy, Sushil, with the overall implant. And this is a conscious patient who is nicely talking to us, who is already negotiating his discharge minutes, actually. So he wants to go home tomorrow. And we haven't seen this performance, 10 years, 15 years ago. So I think it's wonderful, Those were times with snaring, other things. This is all gone. It's much more controlled. And I think it's very beneficial for this age group.
Which is actually also the one-day discharge, which is proven in the TVT registry, as you well know, and also in the optimized study, and in the report of the individual centers that reported on the overlay, that the discharge is really one day, which is very important in many areas of the world. Here in Germany, as you know, it is not such a big deal because we need to keep the patient in the hospital at least for some days. Anyway,
only 4 days now. So even Germany has come down for a total length of stay from 9 days down to 4 days for those TAVR patients, irrespective of age. And we know that the oldest patient actually treated here in Mainz was 101 years old. And even with 99, we have long-term survivors of 5 years after TAVR, which shows you that you're taking away a significant risk factor actually for mortality.
I want you to see that I'm holding the wire. I do something, Sushil. So at least
we can always increase
there.
this. We can always increase this. We've just put the wire out.
Tomorrow, Ebert is on call, actually.
Yes.
So,
Alles gut. Die neue Klappe ist drin. Es funktioniert schon alles.
So you can see.
Can I ask a question?
Sure.
So one of the things that I've been pushed to do, and the group here has pushed us, is if the PR is normal. This is an AFib patient, I think, but if the PR is normal and a narrow QRS,
yes,
we've been doing the pacer from the groin, and if the membranous septum is 4, we do the pacer from the groin, do a quick EKG after, and pull the pacer at the end.
We always do that.
To that point. Do you guys always do that routinely?
Well, we tend to do the pacer from the groin, especially if the patient is low risk for a pacing situation, and if the patient has a pacemaker in place. Actually, we use often a jugular approach because this is easier for those patients who are borderline very old to actually do this. And to have the possibility for 1 or 2 days to get a pacer in quite rapidly. We always pull the pacer in the hybrid OR. So it's always an early, we don't leave the pacer in. So it looks very fine. Can you, Regie, can you put the pressure curves, das EKG und Drucksignal bitte in die Übertragung? So now you see, I think a perfect result, Sushil, you like it? Hemodynamically, the ECG looks great, 93 years old, no gradient whatsoever, and we have no AR whatsoever, at least according to hemodynamics. You see the blue line is perfectly flat, so I think nothing that could be better, and his blood pressure rose from 110 to 160, which will now be lowered, and this is typical for these patients, that they then have higher blood pressure. So
and the QRS complex is small, as you can see here. So we achieved the goal of a high implant, a good implant with a good result.
Yeah, we'll share with you now, if we have time left, we'll share with you an aortography to see that we really have no AR left, and we will also close here with a modern Manta system. So we have not used ProGlides or ProClose, so we used here a Manta sealing for this old gentleman, which means that after 4 to 5 hours, he will be mobilized already.
So is
So
that
Sheila, are
the,
you
is that the
using
closure?
Manta or
We're
are you
using Manta in this
per
case.
cluster?
We're using Manta in this case. So
Is
this
that you-
patient,
is that what you do routinely, Stefan?
we do it routinely in 1/4 to 1/3 of the cases. It's of course a little bit more expensive, but we've seen that to use it in stents and other situations. Okay. Yeah. So here we have a look. Perfect. And looks perfect. Very good. A late shot, mild, but otherwise perfect. I think this will
A mild
seal
regurgitation.
nicely.
So
So we have.
I think it's important, like, you know,
Yeah.
there's a little bit of AR, but again,
I see.
your
Yeah.
hemodynamic tracings look great. He's 93. I
Absolutely.
expect a lot of that to get better over time.
Yeah.
So, you know,
And we know that the nitinol gets warmer, and actually we see that over time. So we're fast nowadays, but if we wait 10 more minutes or 20 minutes,
That's what I was gonna
actually
say,
the AR goes away. So if we have a late discharge echo, there's no AR.
Yeah, so it's always good to.
and I think your point about looking at the hemodynamics is an important one, right? So
Yeah.
his EDP is flat, it's low. So in terms of what's going to matter for him, this is nothing, and this will get better.
Yeah. Okay, he wants to get up already because he feels well, and we just close now the groin so that he can move out of the R as he is.
Dr. Kidali, can I ask a question?
Yes.
Also, yeah, it's going to
I think we have a question here from.
Yeah,
Sanjay. Please
we
go
just
ahead.
show you the commissural alignment perhaps in two planes.
Okay. Sure.
Huh?
Okay.
Yeah.
So we see projection of the left coronary here, the LAO cranium, and you see the CTAF. And the left main is, so I think the commissural alignment is perfect here in this case.
Yeah.
As projected.
Yeah.
Exactly.
So you can nicely see it from the markers. So, and also you see coronary access after his left main intervention is also very nice. So we have a good rotational space. The cusp is large, and access will be there. So I think overall we're talking about a gentleman that even under German conditions has exceeded the normal lifespan of a male person in the German cohort already by 15 years. So he's most likely to have, at the age of 90 to 93, to have an accepted lifespan of another 4 years, 3 to 4 years with this age group in Germany. So I think this is also a message from the geriatricians, and it's important that these patients keep mobile and that they can have their everyday life back without having symptoms. Eberhard.
Yeah, the pressure is coming down to 150, 140, which is good.
So I think we have one question here from Sanjay. Go ahead.
Yeah.
Thank you. That was a wonderful case. My question is that when you do a right Cospl overlap view, for example, in an RAO caudal, how do you confirm the frame alignment? That you need to look at the frame also. How do you decide that your other side of the frame is not above the annular level? And is that a concern? And because see, we are learning.
Yeah, and that's a very good question. Actually, this has been shown. If you do the right and the left, you're talking about the overlap, right?
So I think Sanjay's asking the question, you know, you went from RAO to LAO, and the LAO is to confirm the position of the other cusp. So
Right.
Yeah.
That's correct.
Also, that the lower end of the valve, if it is not aligned, it's not,
right. This parallax, right? Parallax.
Yeah.
How do you make sure that the other side of the valve is below the annular level? So what's your method of confirming that when you're going from RAO? Do you look at the coplanar in between, or you go from RAO to
Yeah,
LAO?
that's what he did actually. That's what he did. He changed from RAO to LAO to make sure that this is that the valve is really subannular.
Right.
That's what he did.
And this
the
was
RAO, and that was the LAO for confirmation.
Exactly.
So we did this before release, as you see, and the distances were not that high because we were coming from an almost AP caudal 30 to a 15-15 LAO caudal. So this is why it was not as apparent, but I think that's an important move, and it's always checked in both planes.
Right.
Yeah.
So I
Any
know
more
you
questions,
didn't cross
guys?
over. You don't have access on the other side at all. So is that your technique? You do two access points on the
less
right?
access points.
Yeah.
So you see, we have only access. So there's only a 4 French, very small safety line in, just to have a wire in order if something happens to the vessel, we can always support a stand situation, or also an occlusion balloon if we had to. But it's a puncture on the same side, no crossover. Also, no second groin being involved. This means less bleeding complications in the very elderly. So we have only one leg involved. So you can concentrate your pressure bandage on this side for a shorter time. And the second thing will be a TR band on the radial approach. So this means minimum hematoma, minimum vessel damage, and best outcome on vascular complications.
That's great. And that's a nice technique there. And so you'll do an angiogram after the Manta, or
yes, yeah, you will see that. Yes, absolutely. So you'll get, and the second access port is also for the control. So we control with a groin vascular angio. We control all punctures and all closures. So you will be able to see that there is no blood leaving the vessel. Okay. So we have a height of 3+1 for the Manta system that will now deploy, and you'll nicely see the platinum marker, and you see here the system going in. We have now the Manta system, which Henrik Trede is putting on the wire.
Can we see that? There we go.
Yeah.
So for those that are not familiar, could you briefly describe the Manta? Is it just an angioseal type of device, or?
It is an angioseal type of device where we have a folded pledget actually that supports with a single device a full closure. And what is very nice is that you can even puncture bypasses or stents and fully close them, which is not possible with the ProGlide system. So this is something that we would put on pericardial bypasses and other types of stents in the groin if there has been a vascular intervention. And we also do this if the patient is calcified, and actually the Manta system doesn't need a needle engagement, but comes directly from the vessel, has a folded pledget, goes back, and it supports much larger volumes than the other possibility, which is a combination of a ProGlide and an Angioseal 8F. So you see, it's a single situation. We have full control. We have the wire in. If there's no bleeding, we take the wire out, but we can have the wire in for support until the last moment. And you can see there's no bleeding whatsoever. Very nice groin, and he will be able to walk tomorrow.
That's
See,
great.
we put the wire out. It's great. No bleeding, very controlled, and it's a 1-minute closure situation.
We can also show, if you like, the final angiography.
We show you the angio of the groin. So we go in an REO 30 projection for it, as we use the right groin. Ich mal gehen auf Gefäße,
Ist auf 2 Bilder, ja?
Ja, mal.
Super.
Sekunde, wir sind schon drin. 2 Bilder ist.
Where's the...
Okay, we're ready. Soll ich das Kontrast geben? Bei
Ja,
der ein
gerne.
bisschen kleiner. Sekunde, das ist ein bisschen groß. We just inject.
Okay.
Ich gebe ein bisschen vor, warte.
Ja. Echt offen?
Guck mal, ob du...
Okay.
Sehr gut. Okay, there we are. Okay.
Ready,
Set.
go.
And you see, very nice.
Good
Perfect.
Yeah?
That's
Perfect
great.
closure, no impairment, no vessel diameter change, no stenosis. So I think that's also a very important point. And our vascular surgeons in Henrik's department really like it.
Yeah, we keep on using it also for other surgical indications. Yeah,
also. Yeah.
for many
What is
things.
the-
It's a
it
great
goes up to
device.
18 French you can close, or even bigger?
Yeah, it's 18 to 20 French, and you see this is the system, single approach. You just have to know the depth of your vascular system, so to the skin level.
There are 2 sizes. There's a 14 French size and an 18 French size, and this is the larger one which we used, which holds up to 20,
TAVR
21.
devices. Yeah, it goes to 20, up to 20. It's officially 18.
Wonderful.
I think our time is over,
Martin-
Sushil.
Yeah, Martin, Hendrik, Stefan, Eberhard, really want to thank you for a great demonstration, a great case. You illustrated a lot of key points, and whether it's low risk or high risk, the procedure technique is the same. And I think whatever it is, I think Saurabh said it earlier, you need to get optimal result, and this is a great case in this patient. Thank you so much.
Thank you
for
very
joining
much,
us.
Sushil.
Thank you,
Thank you.
Sushil.
Thank you.
On a
Best greetings to India.
Thank you.
Yeah,
on a
greetings.
personal
Bye-bye.
matter, Sushil, I have to give a lecture in about 3 hours, so I'm driving back. I hope I'm going to arrive on time. Okay.
Okay, we'll accommodate. No worries. Take care, everyone.
Okay. You take care.
1 minute.
Thanks to your team as well.
Yeah,
Thanks.
1 minute.
Bye-bye.
Thanks a lot. 1 minute. What we were done this time is, sir, because in the Zoom platforms we were seeing in a very small thing, small windows. You are actually seen like Amitabh Bachchan of our country now, because it's projected on the big screen in the PVR cinemas, and all of them could appreciate the details which you showed in a better way, because all the entire proceedings is streamed on the bigger screens across 10 hubs in the country, sir. Thanks for joining.
Oh,
You are
yeah.
very much
One of the
clear.
things we did differently this year is they created regional cities, rented movie theaters, and
I see.
people gathered for the meeting. So thanks again, and
Thank
all
you.
of you are on the big screen, movie stars.
Thank
No,
you.
you've always been.
Grube
Stefan
sir with
doesn't
his
need the
colored
big
specs.
screen.
Dr. Grube
All
with
right.
his colored specs looks like a hero anyway.
Yeah.
So he
Take care. Thanks for having us.
Thank you.
Thank you.
sir.
Again. Take
Thanks.
care.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Bye.
Dear friends, greetings from Fax Foundation, TCT India South Asia 2021. In this video, we will learn about the live case learnings about Dr. Eberhard Grube's TAVR case. We have learned how to do a single femoral artery puncture using only one femoral artery side and others being free. The idea mantra was doing a 4 French sheath down with a thin wire below, and then focusing and targeting the right side puncture and the puncturing in the common femoral artery in the appropriate site. And then later also this 4 French sheath will work as a baseline for us if at all if there's the need to control some problems. So the pigtail is being sent from right radial artery, and then the venous axis is obtained from jugular. So in this way, Dr. Grube's team felt that left femoral artery and veins are totally free, and patient can become ambulant more faster within 6 hours. We also learned how to deal in the patients of coronary artery disease and severe Iotic stenosis. If a patient has a critical coronary artery disease, which tends to become ischemic when you have pace with a rapid fast heart rate during TAVR procedure, like be it the left main or the ostial LAD or proximal LAD disease, we tend to fix up the coronary artery disease first before the patient is taken up for TAVR. In this example, what they have shown, they did left main bifurcation stenting and brought the patient back after a month for a TAVR procedure. And Dr. Saurabh and others also felt that if the coronary artery disease is not very critical and aortic stenosis sometimes is critical, we could do the other way also, or treat only aortic stenosis by TAVR without interfering with the coronary artery disease. But when you're planning with core valve and the patient is more younger, where is likely to get events even because of coronary artery disease, it is better to tackle the coronary artery disease before we do TAVR, because sometimes there could be slight challenges in accessing the coronaries after core valve implantation. There is also, we learned about the sequencing of therapy, when to do surgical aortic valve replacement, when to do TAVR, and again, if required, another procedure of TAVR. Dr. Grube felt like when the patient is 60 plus or 70 plus, probably the first procedure could be surgical aortic valve replacement, followed by, after the degeneration happens, after a decade, you could do TAVR, and if at all is required, third procedure also could be TAVR. So TAVR is the way to go. That's what Dr. Grube felt. But the only exceptions could be if a patient has a smaller annulus where it needs aortic root dilatation and surgeries, enlargement surgeries, which are little complex, and only competent surgeon could handle such procedures. But if possible, we should always try to do such procedures and try to put an appropriate size valve. And then when later on, if requires, patient can go for TAVR and TAVR. Especially in the scenarios where we are tackling younger patients, little more low risk patients, he felt this is optimal. And he also thought doing surgery after core valve implantation. It is not easy to remove the core valve surgically, and it could also lead to aortic ruptures and probably root procedures and other things which surgeon should be very comfortable in doing it. So that's why it is always preferable to avoid doing surgery after a core valve. So probably surgery after doing a balloon expandable valve could be easy compared to doing the surgery after a core valve. So that's why he felt surgical AVR followed by TAVR and TAVR could be preferable sequencing of the order in treating these relatively younger patients. We also learned about low flow, low gradient, but severe aortic stenosis, which were there in this patient. This patient had a severe LV hypertrophy and LV dysfunction, which could lead to low flow, low gradients, but severe aortic stenosis. And as it is documented, even by the continuity valve equation areas, as well as dimensionless obstructive index, which all correlated with severe aortic stenosis. And in fact, such patients could benefit more than the patients who have higher gradients. So this point is a very valid point, which is very relevant for us in day-to-day clinical practice. The predilectation of the valve, when to do, when not to do, and what are the recommendations. If you have to know, then Grube felt he doesn't do predilatations. He does it less commonly, maybe in 15-20% of cases, but 80% of the time he felt it will avoid embolization of the material and probably stroke risk. But if a patient has a severely calcific valve, and especially bicuspid aortic valve, where there could be problems in the traversing the valve or crossing the valve across the aortic valve, he said we could tend to do predilatation. But word of caution is, again, predilatation should be done with a little undersized balloon. Suppose patient has a valve annulus of 24 to 26, probably you should take 20 mm balloon and dilate it. It is just to make a passage for the valve to go in. But at the same time, we should be geared up to make the valve ready, and in case the patient develops severe aortic regurgitation, we should be in a position to implant the valve without much wastage of time. So that's how we need to prepare the valve before we even do predilatation. Then other important thing what we have learned is from them is a Cospl overlap technique, and the right cusp and left cusp should overlap, and the left non-coronary cusp should be kept on the left side. And the valve positioning wise, you position the valve in the RAO first and see it on the right side, and then go to the LAO and check the position on the other side also. And this is what is standard Cospl overlap technique, which is recommended now to prevent valve going too deep in, and this will keep away the membranous septum, away from the membranous septum, which could, on impinging, which could lead to AV blocks. So it was stressed upon for a slow dilatation, slow release of the valve, and do not allow the valve to dive too deep into the LVOT, which can avoid the development of AV block. And he also stressed upon the final aortic root angio taking and gradient measurement, which will confirm to us there is no aortic stenosis and there is no significant aortic regurgitation. And it is mandatory for us to check post-procedure. And after the end of the procedure, it was effectively shown that how Manta device could be of advantage compared to the previous per-close devices. The Manta device is a device which can close up to 20 French, though recommendation was said to be 18 French, but they said they could close up to 20 French with one device. And post-procedure also, it was effectively shown that the arteries do not get pinched, or there is no vessel injury at all with this Manta device. And that's how only one side puncture, and that was also effectively closed with one Manta device. And this all helps the patient to become early ambulant. So thus, this nanogenetic patient, 92 years old, with severe aortic stenosis, LV dysfunction leading to low gradients, associated coronary artery disease, which was effectively tackled pre-procedure and then taken up for TAVR, and predilectation done with undersized balloon, and then probably Cospl Overlap technique using that, and optimal positioning of the valve was done, leading to finally no aortic stenosis, no aortic regurgitation. And patient in the end was joking that when is this time for discharge? So they felt that they could be ready to discharge, get discharged the next day. Thank you. Hope you all enjoyed this live case and this format of live case learnings, which I thought would be more make the things very clear for some of you who couldn't follow the discussions during the live case. Thank you. Yours, Dr. A. Srinivas Kumar.